So, my dear friends, Gabor, Ignacio, we are together here to speak about PFA and maybe the novel indication that we may have with PFA for the posterior wall isolation. I am Serge Boveda from Clinique Pasteur in Toulouse, and maybe you can introduce you.
Yes, my name is Gabor Szeplaki. I work at the Mater Private Hospital in Dublin.
I'm Ignacio Garcia Bolao from University of Navarra, Pamplona, Spain.
Excellent. If we have this new indication of the posterior wall isolation, what is your main indication for this kind of ablation, actually?
I think it's very nice that there was a study which proved that you can do the procedure safely, but I'm a bit conservative. So my approach to a first de novo patient would be a pulmonary vein isolation, even if it's persistent atrial fibrillation. And usually I do posterior wall isolations for repeat ablations or redo cases. Now there are some exceptions. Let's say if you're doing a PVI and you can't cardiovert the patient after the PVI, then maybe I would do the posterior wall. But as I said, for the first procedure, I'm quite conservative.
Okay, so not for first intention.
Not for everyone.
Okay.
Yeah.
And you?
Yeah, we are a little bit more aggressive. I don't mean to be right, for sure, but for persistent patients, for first procedure, we do PVI and we do posterior wall isolation. But I mean, at the end, it's true, as Gabor said, that we do not have clear data comparing in a randomized fashion PVI plus posterior wall versus PVI in the first procedure in persistent patients.
Yes, absolutely. I have to say that I am a little bit like you for the first intention in the persistent AFib patients. We are aiming usually to do the posterior wall isolation. But it's true that we don't have real randomized data with PFA. But what about the Advantage trial? And do you think that this may help go in this direction, or what are your thoughts about that?
Well, I think that basically with the Advantage trial we have some data, important data, because we now know that posterior wall isolation with farables is effective, is safe, and so we are more prone to do it from the very first beginning. One of the things with farables is that posterior wall ablation or isolation or whatever you can call it is very easy from the technical point of view. I would be in the, let's say, the Gabor's side if you were asking me about doing posterior wall isolation with radiofrequency. I would say no, definitely no. But with farables, it's technically is quite easy, quite straightforward. So
easy in expert hands.
Yes, well, for sure, everything is easy. Yeah. But I would say that even posterior wall isolation with radiofrequency in expert hands, is not so safe. I mean,
yeah, because we have the risk of adjacent lesions, and this is true that with PFA we have this security that has been shown in the Advantage trial. So indeed it's a feasibility trial that shows us that this is feasible. Should we do it? This is another question. We are missing some randomized data, more data to come, absolutely. But I think that, yes, this gives us the base for doing eventually this kind of ablation. Okay, Advantage was without FARView, but FARView, would it be for you, let's say, another reason to do it in a different way, or maybe with better expectations? What is also your thought about that?
No, I think that's a very relevant point, because and I truly agree with the FARAPULSE device. It is very reasonably easy to do something on the posterior wall, but I think a 3D mapping, and FARView is a great example. FARView is very helpful if you're delivering lesions outside the pulmonary veins. In my practice, it helped me even with the pulmonary vein isolations. But if I'm talking about the posterior wall isolation, I think some sort of 3D mapping like the FluoroView is very helpful. Now again, we need the trials. The advantage is great because now you have the labeling for the persistent cases and you have a labeling for the posterior wall, so you're covered. But we still don't know who's going to benefit from the posterior wall isolation. But for me, the 3D mapping helps. It reduces the fluoroscopy time, and you can deliver the lesions quite efficiently and safely.
So for you both, if you were dreaming about something for having more evidence for doing the posterior wall isolation, what would it be? Would it be a randomized trial? Would it be more registry data? What do you think is needed now to move forward in this direction?
In my clinical practice, I would definitely love to see a randomized trial on repeat ablations and what to do, let's say, if the pulmonary veins are isolated in a repeat ablation. So I think that's one trial I would love to see. The other thing, what I really like to see is some sort of guidance on who would benefit from a PVI plus posterior wall isolation at the beginning, because I don't think everybody needs it, but I get the point that if you can deliver the lesions safely, then that might be the way to go.
So maybe some sort of a Kapla PFA trial, something like that, a kind of...
Yeah, but you have to repeat it because it's a different technology.
Absolutely, it's completely different.
Yeah, definitely we had data on PBI plus techniques, lines and so on, but this was another era, radio frequency, point by point, and now what I would ask for in the case of PFA is for sure randomized data on persistent, randomized data on posterior wall isolation. So, yeah.
And if we come back to the FluoroView and the help of the FluoroView, what is your opinion the features that are helping most? Is only the 3D image or some other options that may be interesting for posterior wall isolation?
I think you can get some sort of sense on contact, lesion placement, and let's say if you want to do the overlapping lesions, then you're guided completely. So that would be my answer.
Yeah, I'm going to be a little bit extreme, and I remember Gabor also participated in the Navigate trial, and I don't know you, but at the beginning I thought for myself, okay, I'm going to use this device, the FluoroView, in 20-30% of my patients. I don't know you now, but for me, FluoroPulse doesn't exist anymore. Yeah,
yeah, but you're right. It's very difficult to step back and sit back in an old car.
And believe me, I wasn't in a extreme positive way of thinking, but now FluoroPulse doesn't exist anymore, and everything is FluoroView for us, for me at least.
So even for the PV isolation only?
Yeah.
Okay, for all cases you are using?
Yeah, we are, at least
our practice has changed as well, and as we all are doing sessions and teaching other physicians, I think the FluoroView is a great tool to teach the technology. If you think about even the PVI, the rotations and the coaxiality, I think it has the advantage.
Yeah, it's a kind of the missing link that we have now, because it's true that before, in the past, as you were suggesting, we were doing blinded ablation, because it's true that it was difficult to have real information about the contact, and now with the field tags, with the fact that we understand a little bit better the overlap of the lesions, these kind of things, it's true that it's an advantage without playing with the words, but it's a big plus, yes, absolutely. But in my opinion, if I may, it's even more important for extra PV ablation, because for the pulmonary veins, with the guide wire, you have some kind of reliability about the stability, and but for the posterior wall, you cannot use the guide wire. So you are really floating in the chamber, and having some information about the localization of the splines and in my opinion, even if we can discuss about that, but the field tags are giving you also the information that you did an application in this zone, and it's not needed to repeat when you did twice. It's not needed to go back again. And sometimes, if you don't have this, you may go back and re-ablate in zones that maybe are not necessary. So it's for me, yes, it's an advantage, especially for extra PV ablation. But it's true that for the pulmonary veins, it's also a plus.
Yeah, I think field tags are also important. For example, it's a common problem sometimes, you know, that you leave in a small left atrium, you leave a gap
Corridor,
in
yes.
the posterior corridor in the posterior wall. So in that case, the field tags are going to say to you, okay, let's go and close this because you can have a roof-dependent left atrial flutter. So yeah,
Absolutely.
I agree.
Would you like to say something else about indication of the posterior wall isolation, or so if I understood well, you are not doing first intention in persistent patients. You and me, we are more proactive, let's say, in this matter. So we are doing more systematically in persistent patients. What about the redos? Maybe Gabor, if you can explain us a little bit your strategy for the redo patients.
Yeah, so for the redo patients, the threshold to do a posterior wall isolation is very low. As we said it already, we don't really know who's benefiting from those procedures, but I think for me, as in a second procedure, I wouldn't think twice. And yeah, we just touched the field tags. It was very nice to see when we did the Navigate trial that the field tags were correlating with the remapping data and also with the 3 months remapping data. So you can really rely on that. So basically, I stopped doing remaps after the procedures because now I just trust the field tags. But yeah, for me, the redo is a real good indication. Yeah.
Yeah, very interesting about the remaps after. Are you doing remaps after?
Not always. For redo patients, our strategy is to go to high density mapping with Opal, usually, especially if the redo comes from pulse field ablation, because we want to know what is happening there. You can go still forward for another Farapulse procedure, but we prefer to go and to see why this patient recurred. And then usually we go for treatment of the scar or redo PVI or whatever, or if the patient was a paroxysmal patient, we do the posterior wall then in the second procedure.
So now that we have the label for posterior wall isolation, what is your workflow for doing this extra PV ablation? Do you have a special approach, Gabor? Maybe first.
Yeah, so my approach is I try to keep it simple. As we already said, I'm trying to use the FaraView and the 3D mapping integration. And then usually I would start doing the isolation on the left superior side and then go to the left inferior pulmonary vein, then create a line between the left inferior and the right inferior and cover the inferior part of the posterior wall, go up to the superior part and come back. And then you basically cover the whole posterior wall. Usually I don't do the rotations, I just move the catheter. As with the field tags, it's very easy to see when you're overlapping with the previous lesion. And I think it would typically take altogether 60 to maximum 70 applications to isolate even in a big atrium.
17 applications, okay. And flower or basket? Flower, all applications?
Sometimes in the far left inferior part, I still use the basket, but in majority of the applications, it's a flower on the posterior wall. Yeah.
So you're doing a counterclockwise posterior wall isolation. Yeah. And you, Nacho?
Well, you know that classically, without integration, without 3D integration, We tend to reuse the typical Olympic rings, trying to get redundancy, anatomical and electrical redundancy. And
in flower.
In flower, yeah, always in flower. We started that right superior, but I mean it depends on your workflow. It's not so important. Now with FaraView, we are a little bit more liberal because with the field tags I think you have much more information about the undercovered regions. So we are not so strict in terms of doing the Olympic rings. And as Gabor said, I think one important trick here is that anything you try with Farapulse, you have to keep the simplicity of the procedure. So if you do posterior wall, it wouldn't take half an hour more. And, you have to keep the simplicity, and with Farapulse you can do that. The same holds true for FaraView. I mean, FaraView is an additional tool. It can help you, but we don't try to get a full chamber map, and we tend to go as map on the go strategy, and it's simple and effective, as Gabor mentioned previously.
Yes. So if I should say something about the system, simple, effective, and safe are the three words of, and we need to keep that. I think that this is really important, and it's true that the addition of FaraView is giving maybe more effectiveness, especially for the posterior wall, because what I learned personally with FaraView is that when I thought that I was effective by really having a good contact on the posterior wall without the FaraView, was not really true with the FaraView. So I think that the FaraView will help us to have more efficacy about the contact with the tissue. And also, what I learned is that in some regions, and especially in the inferior veins or the inferior line, the posterior line between the two inferior veins, sometimes the basket may be useful because the flower in this region sometimes is floating a little bit. And this is what I learned with the FaraView imaging and reconstruction. So it's giving us probably, I think, or at least we hope, more efficacy with at least the same safety, and without adding too much complexity, because this is what you are saying. What is important is to keep this feasible and reproducible, and this is, I think, the big advantage of the FaraView, that is bringing us more effectiveness with the same safety and also the same simplicity of performing.
By the way, do you cover a lot of the inferior part of the posterior wall, or you go very inferiorly, or you are more conservative? I'm curious on to both.
There is no rule about that, but if you ask me, yes, personally, I go very, very posterior, and I do really the let's say like the floor of the left atrium, so very, very low line.
No, I don't go very like deep or inferior. Usually I do this box like in the old days.
Covering the,
And you, Nacho?
in the middle,
Yeah,
just in the little table. I don't go very, very, very inferior and posterior, but yeah.
Okay.
But I agreed on the point that we have to keep the procedure simple and safe, and these studies are very important. What I think we should also mention is although it would seem like a good idea to do applications everywhere in the heart and everywhere in the atrium, personally I would limit using the Farapulse technology on the posterior wall and the pulmonary veins.
Yeah. So we were discussing just before about a randomized trial with or without the posterior wall with PFA, and should we need also another trial with or without the FaraView for the posterior wall, just to be sure that it's really needed? we think it's important, but should we have something like that? Why not?
It'd be interesting.
Yeah, lots of projects. I
Yeah.
think
Yeah,
we have
yeah.
still a lot of work to do. So, okay, I think it was a very nice discussion.
Thank you very much.
Thank you, Serge.